All right, thank you, Mara, and thank you everyone for the invite today. And I am honored to be here. And Mara was one of my first continuity care residents when I was at University of Chicago, and she knows well enough of my love for this part of medicine and this part of dermatology. So I'll just be going through basics of what connects dermatology with tropical medicine and what connects dermatology with global health specifically. But I got into this area of dermatology, there was no such existence of global health and dermatology at that time 2 decades ago. And now we're so blessed or lucky, or I guess people are realizing the value of our field for the skin signs of systemic disease. So these are pictures I took when I was a resident. I went to Tanzania, where there's a big dermatology training center in a town called Moshi. It's at the base of Mount Kilimanjaro, and the center is called the RDTC. And these are pictures I took of Mount Kili and while on safari, and of a Maasai tribeswoman. So some of these trips, you know, you get to know the culture, you get to know the endemic conditions in that area. So I don't have any relevant conflicts of interest or relationships with the industry. My only conflict is that I usually spoil travel and food for everyone after this talk, so I'm sorry about that. Travel, unfortunately, has already been spoiled for us, unfortunately, because of COVID-19 nowadays. So let's go ahead. So there's a Tropical Disease Research Fund. That's a collaboration between various organizations, and it focuses on these diseases listed, from leishmaniasis to filariasis to dengue. When we look at the NTDs as they are described by the WHO, and these are the neglected tropical diseases, and I listed them all here. If you look at the ones in blue, all the ones in blue primarily present with a dermatologic skin manifestation. So in the realm of tropical medicine, tropical dermatology has always been an extremely important field. In fact, the International Society of Dermatology, which is called the ISD, it used to be called the International Society of Tropical Dermatology. So the connection between dermatology and NTDs, nearly all NTDs have some cutaneous component, and unfortunately, few NTD organizations have dermatology support for their clinical or research endeavors. In Europe, still the bridge between infectious disease and dermatology is still very strong. However, in the United States, in the past half century, dermatology and infectious disease became separate fields. If you look at the European meeting, it's still called the EADV, so European Academy of Dermatovenereology. And actually, it used to have syphilology as part of its description too. So this was an old handbook on tropical dermatology. So this is a very recognizable rash in tropical medicine, the serpiginous track on a foot after coming back from a vacation in the Bahamas or any Caribbean island, and this was cutaneous larva migrans. This was a picture actually shared by Dr. Ed Cohen and presented at the NIH Grand Rounds. And as most of you know, this is myiasis, or caused by botfly larvae. And so this is something when you go to endemic areas such as Central or South America or parts of Africa, there are different species of the botfly in Central America and the tumbu fly in Africa that can cause these larvae to deposit in the skin. And there are various ways of taking them out. You can do occlusion, you can inject it with Lido, and the larva kind of pops out. So travel is one of the reasons that we see in global health, the transmission of disease. War is another method of being in contact with local populations. We have military troops and bases all around the world. Even in areas where there is no active war, the United States has active military presence. So the military actually is hugely interested in tropical medicine. And over a decade ago, I actually, as a civilian, did the military tropical medicine course. It's called the MTM. All military physicians at some point are encouraged to do this course, and it's held in Bethesda at the Uniformed Services University. And tropical dermatology is a huge part of this course, and I've been honored to teach that part for the past few years at this course. In this course, you get to do malaria smears, stool smears, you get to learn all that you get to learn in the realm of tropical medicine. So with the military and otherwise, when we went into the Middle East, leishmaniasis became of great interest to us as a research topic. And this is leishmaniasis tropica in a patient from Afghanistan. So the classic lesion of cutaneous leishmaniasis is usually an ulcer with rolled borders on exposed surfaces. And another condition that we have very few pictures of, but it's the pulmonary form of anthrax that is what we are concerned about for weaponization. However, cutaneous anthrax, the classic lesion for cutaneous anthrax is erosion with black eschar with surrounding edema. There are very few pictures of cutaneous anthrax, and this was lended to me by a former professor of mine at the London School of Hygiene and Tropical Medicine. So I just want you to see this picture and just sort of burn it into your mind that this is what cutaneous anthrax looks like. The surrounding edema is one of the key factors. Adoption is another way where we need to know about conditions that are and can be seen in migrant populations. There are now, unfortunately, a lot of international adoption programs that have closed down due to politics. However, when I wanted you to see that the countries that were popular for us adopting were Ethiopia, China, Russia, and now still there are programs from Guatemala, but those were the top countries. And most university centers have international adoption clinics where children get hooked up into, and great resource for parents for continuing care of their children. Refugee arrivals, so in 2008, 2010, these were the countries, and if you run your eyes over the following list of countries, you'll see that a lot of the countries are in the tropical areas of the world. Refugee arrivals, still these numbers are pretty similar. However, they have gone down significantly in the past few years, again, due to policy. And tropical medicine encompasses migrant health hugely, especially in Europe. Immigration, so the legal immigration to the United States through the green card method, we are actually 20% of the world's migrants live in the United States. So we have a history of migration. This is a country of immigrants. And I just wanted you to know that there's various waves of migration that have happened to the United States. And with the various waves came various conditions that we needed to know about throughout the history of this country. So legal permanent resident population, again, these are pretty much the same countries in the last decade. However, the numbers have declined. Again, run your eyes through this list. A lot of the countries are in tropical areas of the world. Environmental change. So unfortunately, a very hot topic. And for those of us who do believe in this, there have been warnings, and I was lecturing about this 15 years ago, and there was a big conference on climate change and vectors and diseases that we will be seeing more and more because of climate change, and they have come true. So the deadly dozen diseases in 2008 were named that could stem from global warming. And the hypothesis was that as global warming ensues, the vectors that were able to live within a certain radius area would expand. So especially this would be true for mosquito-borne illnesses or tick-borne illnesses, and we'll see more of these conditions in areas where they were not present before. So this was the deadly dozen diseases from that environmental congress in 2008 that were listed. And again, if you run your eyes through this list, you'll see a lot of these conditions have skin findings or a skin rash as the presenting sign. This was a patient who had visited East Africa and South Asia and had come back with this rash. However, the patient had had fever, had had myalgias. And if you learn in tropical medicine, as you learn in dermatology, sarcoid and syphilis are always on the differential. So in tropical medicine, malaria is always on the differential in a patient with fever and myalgia. So this patient was worked up for malaria, for typhoid, till suddenly one physician was smart enough to see this particular eruption and thought about dengue. So this was dengue hemorrhagic fever. The patient was in the ICU and the platelets had dropped down to 10. And the primary treatment for dengue, as you know, is supportive. At the time, dengue was being seen in South Asia, but then dengue fever was also being reported in parts of the Caribbean, Puerto Rico, and parts of Florida, and it suddenly was being reported in the news. So this is a spraying being done in Miami-Dade County. And more, jumping to 2011, we have the vector for dengue all over the United States. It's the Aedes mosquito. And we saw more and more dengue cases erupting in returning travelers. But then we also started seeing dengue in Florida in people who had not traveled, especially in the Keys. This was a red pin that's used to mark outbreaks in surveillance maps. So you can see a lot of the places in South America at that time had outbreaks, and South Asia, Southeast Asia. So there is no specific treatment still for dengue. It's still supportive. There's 4 strains of the dengue virus, dengue 1 through 4. So the vaccine needs to be tetravalent. There are companies that are looking at genetically modified mosquitoes, especially an experiment was done in the Cayman Islands through a company called Oxitec, where they rendered the mosquitoes sterile and then unable to reproduce. A year like this that we've had with COVID-19, or when these dengue outbreaks were hugely affecting many countries in the world, also leads to an innovation. And this was in Pakistan, where young people came up with an app that one could download into the phone, and wherever an outbreak was being reported, people could just report the cluster and it would pin it, and the public health officials would know where to go to spray for mosquitoes or to do surveillance. And again, more posters for dengue fever globally. This was a patient that came into the University of Chicago clinic, and actually it was one of our easiest patients of the day. The patient was a healthcare worker, had returned from Central America on a healthcare mission, and the post-it on my template for the day, as Mara would remember, we would have these paper templates at the University of Chicago, and this patient's name next to it, there was a post-it and it said, "Patient says he has Zika." And it was Zika. So this was a morbilliform eruption. This patient came back from his trip a week prior to Central America. It was blanching. He had some lateral conjunctivitis, some mild myalgias, low-grade fever. I think the hardest part of our day was getting the CDC to do the blood test for Zika. That took us a longer time to figure out, and the biopsy just showed that was consistent with a viral exanthem. So morbilliform eruption, like any other viral exanthem, but with Zika, you can also get conjunctivitis. Same patient with the truncal morbilliform exanthem. So this was at the time of the Zika outbreak, and we were seeing it mostly hugely in South America, Central America. And at this time, the CDC came up with great posters that were showing preventive measures against dengue, Zika, and chikungunya virus. So these are the posters from the CDC, and these are very helpful public health campaigns. The role of public health is huge in prevention. And another thing to really know when counseling patients is that the Aedes mosquito is actually a day-biting mosquito. A lot of patients associate mosquitoes with evening time, but the Aedes mosquito is a day-biting mosquito. So the long sleeve shirts and the other basic protections should be reviewed with patients, especially in case of outbreaks. So this just goes over what is an imported case, a patient who was bitten by a mosquito while traveling away from home. Local transmission, a person who has not traveled gets bitten by an infected mosquito where they live, work, or play. And that's why people who were diagnosed with Zika were told to stay at home for a few days after the initial diagnosis. This is my daughter in Pakistan, and I wanted to also point out in global health, there's some innovation, like I mentioned again, we should also look at it as a time for innovation. This is a playpen that is made out of mosquito net, and it kind of folds up like a bagolini, and it costs $1. So whenever my daughter would play out in the garden, I would spray it beforehand. My poor kid, she's got this global health tropical medicine mother. So, you know, she knows a lot about tropical medicine maybe than most 6-year-olds do. But again, this is a pretty neat way, you know, and safe way for kids to play in areas when there's an outbreak for mosquito-borne illnesses. So this was, next patient was a patient who was Peruvian. This patient was in Chicago, actually, and was post-cardiac transplant. It was, the patient was a 42-year-old inpatient cardiac transplant patient, and the consult team was called to evaluate him. And he had fever, inguinal lymphadenopathy, and then had this rash on the lower legs. He had these subcutaneous nodules and dermal plaques with this central darkening. Again, a close-up of his exanthem, these plaques with that central darkening, and it felt a bit indurated. This pictures are courtesy of my colleague, Dr. Eva Parker, and we presented this case at the Chicago Derm Society also, and ended up publishing it. As time went on, the plaques and the nodules became more dusky in appearance. And the pathology actually showed these inclusions within the macrophages. And again, a close-up of the patient's pathology, you see these inclusions within the macrophages. And as a lot of you might have guessed by now, there's very few things that give you inclusions within macrophages. There's leishmaniasis. This patient was from South America originally. This was Chagas disease. And now if you go back and you see he was a cardiac transplant patient. So this patient actually had idiopathic cardiomyopathy that was diagnosed, but in fact, in retrospect, once they got these results and they did serology, they then thought that his cardiac disease was actually due to Chagas disease. So this is Carlos Chagas. He was Brazilian, and he defined the pathogen, vector, host, epidemiology of this parasite. The causative parasite is a protozoa, that's Trypanosoma cruzi. And the main mode of transmission, which all the residents need to know what the bug looks like, is called the triotome bug or the reduvid bug or the kissing or assassin bug. This is Carlos Chagas with the first patient he described the condition in, called Bernice. Various modes of transmission for Chagas: blood transfusion, organ transplantation, foodborne has also been reported now. And as of December 2006, all blood in the United States is screened for Chagas disease. And in this slide, I just wanted to point out that it's interesting how in transplant patients, the kind of skin manifestation I showed is more prevalent for reactivation of Chagas. However, in HIV patients, reactivation is manifested by an encephalitis. So Chagas is endemic in these parts of the world, Central South America and Mexico. It is one of the neglected tropical diseases. This is the distribution map of Chagas disease, all that's covered in blue stripes and blue. This is a picture of the reduvid bug. And if you look at this study, there's different species of triotome bugs that are now endemic in parts of the southeastern and western United States and parts of Florida. And it just shows you mostly one or two species, or the dark blue is about 5 species in that state. Again, we have prevalence of T. cruzi in a lot of our states. The highest states have been Texas, California, Tennessee, and Louisiana. The main thing to learn from the life cycle from us is that it's the flagellated form that the bug transmits to humans. And once the flagellated form goes into the tissue, it becomes from the tripomastigote to the amastigote form. So what you're finding in the macrophage is the inclusions, it's the amastigote form of Trypanosoma cruzi. The acute phase is 1 to 2 months, and at the site of the bite of the bug, you actually see a chagoma, which is a skin chancre, or you can see the Romana sign, which is pretty popular as a board's question, but there's very few pictures of Romana sign actually. That's when it gets tricky after the acute phase. You can actually enter into a subclinical infection phase. And 1/3 of people go on to develop chronic Chagas disease. And that can be divided into asymptomatic, cardiac, or digestive form. So that patient, we think, had the cardiac form. So I think this is very important for us when we're seeing some patients who originate from certain parts of the world, and we're going to put them on some immunosuppressive regimen, that you think of these conditions if they're going to reactivate or not, and do serology for them, perhaps. This is a Romana sign, the unilateral purplish violaceous orbital edema. In the acute phase, you can diagnose by PSR. In the chronic phase, usually relies again on serologic tests. This is the flagellated form. And the treatment is benznidazole and nifurtimox obtained from the CDC. This is another a condition in which you get an inoculation eschar, and I wanted to put this in because dermatologists do end up seeing this in their outpatient clinic. It's the same condition, again an inoculation eschar with that central black eschar on the lower legs or exposed areas. Another one before the central becomes broken down and becomes like a gray-black eschar. This one is near the eye. It's all the same condition. This is African tick bite fever. So for tick-borne illnesses, African tick bite fever is an important one to know in travelers, especially who've been to East and South Africa. It's caused by Rickettsia africae. and transmitted by the amblyomma ticks. And usually the history is somebody's been to that part of the world for travel, leisure, or for work. So the correct medication for treatment of African tick bite fever it's doxycycline, as it is for most tick-borne illnesses. And just for the follow-up for Chagas, I forgot to mention, you have to counsel patients not to donate blood, and a lot of the family members should be screened. So when I was a resident, or when you're teaching residents, when you see a tropical disease case, I think people get excited, oh, that this is the first case that's going to be reported or publishable. So these are things that you have to keep in mind, but I also like to remind in my talks that the history is still such an important part of what we do. And nowadays we're taking histories if somebody's traveled out of the state, if somebody's been to an high prevalence area for COVID. So I think just kind of, put that out in tropical medicine on a global scale. So global health encompasses basically now that we think about the global health of our cities, the global health disparities that exist within our country, but global health also encompasses the health of low income or middle income countries where tropical diseases, the NTDs, exist. So dermatology and global health. This is a picture I took of the Rift Valley in Kenya. And you have to see these animals. One day we'll be able to travel again. So the word safari means travel in Swahili. So we will virtually travel today in our talk. And I love this country of Tanzania. It is where I spent my third-year residency elective, and I fell in love with this country. So it's got the beautiful Serengeti Plain, where the great migration of animals happens. It's got the highest peak in Africa, Mount Kilimanjaro, and it's got the beautiful island of Zanzibar. This is a picture of the island of Zanzibar at sunset. And actually, for a lot of Queen fans or Freddie Mercury fans in the group, if you're listening, you might know that Freddie Mercury was actually born in Zanzibar before his family moved to England. And this is my guide in Zanzibar, and he took me to visit this school, and it was meant to be. The school had a diagram of the skin on the wall. And this is me with park rangers at safari, and they said they recognize a footprint on the sand or the ground to tell what animals were there to track them. And he asked me to identify this footprint. And for those of you, my choices were rhino, elephant, and lion. And it was a lion. And the word for lion is Simba in Swahili. This is the KCMC college, and the RDTC is under the auspices of the KCMC. So if you ever go to Tanzania, try to make a trip to Moshi to see Mount Kilimanjaro and visit this dermatology center. They do remarkable work. This is the main building. This is during my rotation, I saw a Maasai man who had presented with zoster. And of course, as you know, you have to make sure there's no ophthalmic involvement in this case. A lot of keloidal scarring we saw in a lot of Kaposi sarcoma, unfortunately, because of the HIV prevalence in that part of the world. Lots of KS again, and very cute patients we saw. These are all Maasai children dressed up in their red garb. And this was a very innovative guy trying to sell me this wood pillow that would keep my head off the ground and not get any insect bites on my ear. So we'll go to Malawi now. So Malawi is where I was fortunate enough to visit once I started off as a young faculty. It's a landlocked country. This is Lake Malawi. It's full of schistosomes though. Like I said, I usually spoil travels, but you should know it's full of schistosomes. Malawi is one of the poorest countries in the world with one of the lowest life expectancies in the world. The hospital we worked at was in the capital city of Lilongwe. And at that time, they had 2 trained dermatologists for the whole country. And right now, they have 10 dermatology officers and 2 dermatology consultants. The RDTC trained officers go to various countries in East Africa, and that's who the skin clinic was being run by when I visited. This is the skin clinic. And it was also a leprosy center. This was the leprosy clinic room and that the leprosy officer would examine patients in. We would see things like impetigo, but sort of more advanced forms of it. And Mara is right. I loved and discovered the use of gentian violet, which is used as an antibacterial, antifungal for impetigo, for tinea pedis, in lots of countries in East Africa, actually, still, and is very cheap. And we know now that it's active against MRSA also. More extensive bullous impetigo, HIV lipoatrophy, bitemporal. Saw some syphilis cases, condyloma lara. We saw, unfortunately, aggressive and late forms of mycetoma. Pellagra, which was usually a spot diagnosis. You saw the Casals necklace with niacin deficiency. We also incorporated in the global health arena other things that encompass it are refugee health, migrant health, and also provide care. So this was an orphanage run by a local with 500 children who had lost parents due to HIV. So we used to provide services and screen these kids for common conditions such as tinea capitis, impetigo, or scabies. We also saw some genetic skin conditions. So we saw ichthyosis. We saw a couple of cases of XP, unfortunately very advanced due to lack of knowledge and lack of sun protective measures. And we also saw lots of albinism there. That's a whole other talk, but there's a lot of stigma associated with albinism in East Africa. These are a few of the superstitions: that mother had sex with a white man, mother ate the wrong kind of food, witchcraft was involved, and unfortunately, people with albinism were hunted down for body parts in some parts of East Africa. So we did start an awareness program in Malawi. And then an article in the New York Times brought attention to this global health issue. And there's lots that's being done now in many parts of East, South, and West Africa. So this was an awareness day we had organized in Malawi. And you can see that we actually did the advertising through a radio. The local radio did it for free, and people came from villages. You can see lots of mothers carrying their babies. And we had donations of sunblock. And we had a counseling room, and we had 206 patients registered as of last year. Those numbers are pretty stable. This is just in the capital city of Lilongwe. And this program, the residents and medical students that went with us also got to see this when we went. And on travel, you also get to see strange food. And I know there are TV shows about this, but in Malawi, the rural areas, field mice are eaten. So I call this mice satay. But if you look closely, this kid had an impetigo lesion on the lower lip too. And then another area of interest, I think, that I want to point out quickly is IDPs, or internally displaced people. So as the climate change was being reported with vector changes, it was also predicted that with global health and climate change, you'd see more and more internally displaced people. And now we're seeing the wildfires in the West. Actually, a tornado hit our neighborhood just 10 days ago here in Connecticut, and it's just unseen and unheard of. So this is real when we were seeing this in other countries, internally displaced people. So the majority of refugees even now are in Asia and Africa because of a war, climate change, or climate catastrophe. The common diseases seen in refugee camps are scabies, lice, impetigo, fungal skin infections, nutritional deficiency. And again, if you look at after storms in the Philippines, the MSF reported the most frequent diseases we see are respiratory and skin infections. And that we were bringing to light 2 decades ago that dermatologists should volunteer in refugee camps because they're highly needed. And this was in Pakistan, which had major flooding a few years ago. Half of the country was submerged underwater, and a lot of people had to live in tents, and their homes were destroyed. And you can see like this is a pretty graphic picture of a bridge falling apart. 20 million people were affected. The military has to be involved. So that's also over here how the National Guard is called. So in a lot of countries with dengue, with Zika, with flooding, the military or National Guard equivalent for those countries get involved with spraying or with providing help. So these are the various hazards from floods. You can see, of course, flies, hygiene is an issue. There are outbreaks of waterborne diseases, dengue, skin diseases. Skin infections were one of the top things being reported in hundreds of thousands. So again, top 3 skin infections in this condition. So we volunteered at that time, and we set up with the Teledermatology Society of Pakistan mobile skin clinics. I volunteered with one of these clinics in Pakistan, and I could say like there were no prior authorizations involved. The pharmacy was right next door. You examined the patient, you gave the prescription, it was filled right away. We had a person doing scabies counseling. I was itchy at the end of the day though. This is a refugee camp in Pakistan, and children are always excited when they see a bunch of people, what's going on. That's true for all the countries I've been to and volunteered. They're always very curious. This was our dermatology pharmacy. I was unsuccessful to create a queue, I was trying nevertheless. And this was my clinic there. And the most common infections were, again, common things we see, like impetigo, cellulitis, infected wounds, insect bites, fungal, parasitic, and just a collage of all the things we saw over there. And I just want to point out the implications nowadays. We just published a review on skin findings of COVID that we collaborated with our colleagues in France and in Italy. And these are COVID toes that were being reported early on. This is where global health really kicks in. This was a picture shared by Italian dermatologist in Bergamo, who was at the forefront of seeing these patients. And this was shared by a French dermatologist for a paper for COVID toes before we even started seeing them here. And that's why global health, I think, is so important for this information sharing and for providing care and knowing about these conditions before they arrive here to our soil. And once we are able to travel again, I think medical students and residents never forget these trips. They stay with them for the rest of their life, and they also transform them into how to work in resource-restricted settings and become innovative. So thank you, and it was a pleasure to be here, and I'm happy to take any questions.
Great. Thank you so much, Dr. Sethi. This was a wonderful talk. I think it was great for our entire community. These are things that we just don't often see, so it's so good to see it. And for our residents, how much board fodder was in this lecture. So that's great. Right, see, there are a few questions that have been coming in. One, Have there been any recent cases of domestic bioterrorism, related cases of cutaneous anthrax, resembling spider bites like those following 9/11, or, the anthrax being sent through the US mail? Are you aware of that?
So I am not aware of that. I myself personally have not seen any bioterrorism case of cutaneous anthrax. But when I did do the military tropical medicine course, as a civilian, there were 2 lectures I was asked to step out of that I could not attend, and those were the ones with bioterrorism. So those are the 2 lectures I was not allowed to attend as a civilian. But I have not personally seen any cases of bioterrorism of cutaneous anthrax.
Okay, we've got another question from Dr. Vidmar. Dr. Vidmar, I can read it, or if you want to ask yourself, I've given you permission to talk.
I mean, it's okay. In the United States military, we did a ton of civil humanitarian work in a lot of the settings that you were in. We did it mostly in Central and South America and in the Middle East.
Yes.
When you encountered a community that had just a ton of endemic scabies, how did you do this? Did you use tetmazole? Did you use precipitated sulfur soap? What did you use for this huge number of folk?
Yes, great question. Thank you so much. So actually, you're right. Still at the end of the MTM course, the military tropical medicine course, the military directors, which are physicians, still go to Peru, Liberia, East Africa. So they go on humanitarian missions for 2 weeks for a field mission after the course, and do a lot of humanitarian work, which is part of my bias and love for that part of the field. So in the field, it depends, in which camp you're in. So for example, I used a lot of benzoyl benzoate, for scabies treatment, or you used oral ivermectin, actually.
Great. Any other questions? Any other questions from the audience? Okay, that's it. Thank you for those wonderful questions, and thank you for the great talk. Really, it was nice. I remember that Chagas case from residency, and seeing those maroon exam tables. I'd forgotten. Right, everything at the University of Chicago is maroon.
Yes, it is. Yes, it is. Well, thank you so much for having me, and my email is there. And everybody stay safe. And thanks again, Mara, for inviting me.